we need to talk about one of the highest risk revenue functions inside the modern hospital back office. The Centers for Medicare and Medicaid Services recently projected Medicare fee-for-service improper payments at $31.7 billion for the fiscal year. A massive chunk of that leakage happens before the patient ever leaves the building. Part A inpatient claims alone account for $4.6 billion of those improper payments. Certain specialties are bleeding faster than others. Internal medicine consistently generates above-average error rates, responsible for over $773 million in improper payments on its own. This waterfall chart shows how those macro numbers translate directly to daily operations. Even if a practice maintains a strong 95% coding accuracy rate, a $200 million annual billing volume still bleeds out. That 1% inaccuracy margin alone slices off $2 million in lost or delayed revenue. Operationally, that translates to average medical claim denial rates sitting at 5 to 10% across the industry. The reality of managing those denials is resubmission fatigue. Up to half of those denied claims are permanently abandoned, which means that revenue simply never arrives. You do not need to increase patient volume to fix this. Improving accuracy by 2 to 3 percentage points can recover up to $5 million a year, depending on your payer mix. Relying on standard, unspecialized billing personnel to handle complex inpatient coding creates a compounding revenue leak that quietly destroys practice margins over time. This diagram illustrates why inpatient coding is so fragile compared to outpatient fee coding. Every inpatient encounter relies on a central diagnosis-related group, or DRG, assignment. That hub requires accurate input from 4 orbiting nodes: the principal diagnosis, secondary diagnoses, complications, and procedure codes. Omit a single hierarchical condition category code, or sequence a complication incorrectly, and the entire equation breaks. The DRG assignment drops by a full tier, significantly reducing reimbursement. Then add the annual regulatory burden. For fiscal year 2024, CMS introduced 395 new ICD-10 codes, plus dozens of revisions and deletions, demanding continuous retraining and auditing. The sheer volume of these changes drives systemic errors. Research shows 14% of hospital services and over 19% of office visits are coded incorrectly. Much of this stems from documentation blindness. Physicians document the care they delivered clinically, but they rarely use the specific descriptors required to satisfy strict DRG complexity levels. The resulting gap is where the largest errors occur. Recent CERT data proves that incorrect coding and insufficient documentation combined drive over 86% of all improper payments. Every coding error acts as a point of physical erosion on your hospital's financial foundation. Because DRG validation requires precise translation of clinical documentation, putting generalist coders on inpatient charts mathematically ensures downgraded reimbursement tiers and mounting audit exposure. You might want direct control over your billing operations, but hiring your way out of this problem is structurally difficult. Administrators face a 12% nationwide talent gap in certified medical coding. The candidates who are available command a premium. Certified professionals average nearly $63,000 a year in base salary, and specialized inpatient coders demand even more. Looking at this stacked bar chart, you can see how base salary hides the true fully loaded cost of an in-house employee. By the time you add payroll taxes, benefits, mandatory retraining, and management overhead, a single inpatient coder costs between $55,000 and $75,000 annually. Then factor in the burnout rate. Right now, 31% of coding and health information staff are actively planning to leave their current positions. When they leave, you are hit with prolonged productivity gaps. Practices often resort to reassigning unqualified generalists to the inpatient queue, accumulating severe audit exposure during the vacancy. Even when fully staffed, static in-house teams lack surge capacity. When unexpected seasonal admissions spike or surgical caseloads increase, the workload quickly overwhelms available headcount. Those backlogs force the team to code under intense pressure, which directly spikes error rates and triggers immediate payer audits. Building an in-house team presents an illusion of safety, but it forces administrators to buy into high financial overhead, guaranteed attrition risk, and zero flexibility for volume spikes. The optimized alternative bypasses the talent shortage by outsourcing the function to dedicated remote specialists carrying strict AAPC and AHIMA credentials. For staffing lease infrastructure, the financial input is direct, a flat rate of $399 per week per seat for a dedicated specialist with EMR access. This comparison matrix clarifies the operational cost savings per seat. An in-house equivalent sits around $75,000 with heavy attrition risk, while a dedicated staffing lead professional runs roughly $20,748 annually with zero turnover risk. The workflow integrates AI-augmented smart routing to sort incoming patient files into tracks based on predicted complexity. Predictive workload management balances queue depths to mitigate the specific backlog pressures that often lead to human error. The technology runs automated pre-submission audits, systematically flagging incorrect code logic before a human ever clicks submit. Administratively, there is no compromise on security. All access is governed by HIPAA and SOC 2 Type 2 compliance, utilizing encrypted VPN connectivity directly into your practice's existing EMR. The implementation pipeline takes exactly 14 days. Staffingly maps specific workflows, EMR setups, and payer mix protocols before a single chart is ever touched. Utilizing AI-augmented, credentialed remote teams replaces unpredictable administrative payroll liabilities with a scalable operational structure. We have to measure the true cost of an action. Every single denied claim costs your back office an average of $118 in direct administrative rework. Scale that across a standard 250-bed hospital, averaging 2,000 denials a month, and you spend nearly $3 million annually just investigating and resubmitting errors. Compare that chaotic rework penalty to the scorecard seen here. The specialized outsourcing model maintains verified error rates below 1%. The management trade-off requires a shift in perspective. Administrators must let go of physical staff oversight, exchanging it for strict, data-driven accountability via dedicated weekly KPI dashboards. By integrating clinical documentation improvement specialists who proactively query physicians before charts close, you can solve the documentation blindness problem at the source. This structure is inherently flexible. There are no long-term contracts, zero hiring overhead, and you can scale your seat count up or down with 30 days notice. The immediate next step is initiating the 14-day risk-free pilot, allowing you to test this sub-1% accuracy standard on your practice's actual charts.